My dog.
It's just like, we'll revisit that during lunchtime. The ankle and foot. That's the bottom part of your lower extremity.
I don't know what she said.
It's the best place to start. Um, so our ankle joint is the articulation of our talus with our tibia and fibula in the talocrural joint, because that talus or the tibia and fibula make the crural part of the talocrural joint. And then we also have our foot with several different articulations and the same joints in our toes that we have in our fingers. So in any manual muscle testing today, Haley, be careful.
Yeah.
Don't worry, I'm not making you guys test each other's toes. I just wanted to mess with her. All right. So the function of the leg, ankle, and foot is to transmit forces from the body to supporting surface and from the supporting surface to the body. So our foot helps hold us up, right? That's what makes contact with the ground in 90% of the instances of us getting around the world. It provides our base of support and has the ability to accommodate to a variety of supporting surfaces. Our forefoot has the best adaptability to it, and so it is what is primarily responsible for being able to adapt to a variety of different surfaces. The joints of the ankle and foot are synovial joints, and the combinations of movement make the ankle triplanar. So looking at individual joints of the ankle and foot, we have typically individual motions at each of those joints, but together we have triplanar motion. The ankle joint is the talocrural joint, and it is a hinge joint. So we only talk about plantar flexion, dorsiflexion at the talocrural joint. The joints between the tarsal and metatarsal bones of the foot are plane joints, and they have minimal motion. Osteokinematic motions that happen at the foot, there's debate. You can read about the debate. You can care about it if you would like to. But know that clinicians use the oblique axis of motion to describe the motions of the ankle. And so when we look at that, we're talking about dorsiflexion being your toes coming up towards you. Plantar flexion, your toes being you're going away from you. Inversion would be the medial side of your foot coming up towards the ceiling if I was in anatomical position. Eversion would be the lateral side of your foot going up towards the ceiling from anatomical position. Abduction is pointing the toes away from you, i.e. toeing out. Adduction, pointing the toes towards midline, i.e. toeing in. Dorsiflexion occurs in a sagittal plane about a frontal axis, and we have 0 to 20 degrees of dorsiflexion. I will tell you that I will doubt that most of you have a full 20 degrees of dorsiflexion when we do goni measurements in a little bit here, because our resting position, especially when we sleep, we rest in plantar flexion most of the time, and so that is where we get tight very quickly. And unless, with the exception of maybe Savannah, because she seems to be hypermobile every joint, unless you're regularly stretching your calves, you probably don't have 20 degrees of dorsiflexion. We start measuring from that plantar position. Does anybody remember what plantar is? So in a standing position, my leg makes a 90-degree angle with my foot, right? That is the plantar position. So when I measure dorsiflexion and plantar flexion, I'll start at 90 degrees. And it has to be at 90 and then measuring from there. Most people don't have 20 degrees coming from that 90 position because we just get tight based on how our body rests. Plantar flexion occurs in the sagittal plane about a frontal axis, and we have 0 to 50 degrees of plantar flexion. So about 70 total degrees of motion at the ankle is what we should see. 50 degrees plantar flexion, 20 degrees dorsiflexion. Inversion occurs in the frontal plane about a sagittal axis, and we have 0 to 35 degrees of inversion, 0 to 15 degrees of eversion. Part of that has to do with the strength of the deltoid ligament on the medial aspect of our ankle. It limits the amount of motion we get in the eversion direction. That is part of why inversion sprains are more common, is because the deltoid ligament prevents motion into eversion. Abduction, we don't typically measure, so just know what it is because of the combination of motions that we need. So our triplanar motions that we get at the foot. The oblique axis of the subtalar joint causes these triplanar motions because it does not have a single axis. Supination occurs as a result of, or a combination of, inversion, adduction, and plantar flexion. And I had a friend in PT school who made remembering supination really easy for me, and so I will choose to share it with you guys. If I'm supinating my feet, I've made a little bowl to hold my supin. If I'm pronating my feet, I have not made a little bowl. So supination makes a little soup bowl. So I've got to invert, adduct, and plantar flex to supinate. I have to do the opposite to pronate. So I evert, adduct, and dorsiflex to pronate. These are important motions for the foot to accommodate irregular surfaces. And that is just that oblique angle at the ankle, if you really need to see it. But as far as this, why the subtalar joint has an oblique angle and causes that triplanar motion. So during open chain motion, we get abduction during dorsiflexion and adduction during plantar flexion. So everybody take your foot out. Dorsiflex. Which way does it go?
Towards you.
It deviates laterally, right?
Oh.
Plantar flex. Your toe deviates medially, right? So we can see how we get abduction with dorsiflexion, adduction with plantar flexion. In a closed chain motion, the leg rotates medially on the foot during dorsiflexion and laterally on the foot during plantar flexion. And this happens at the tibiofibular joints. And it's just the opposite of what's happening in that closed chain motion, again, because of the oblique axis. God bless you. The end feel of the ankle is firm in all positions or all directions. So you don't have to worry about remembering different things. Just know that we're looking for a firm end feel. What causes a firm end feel? Ligaments, tendons, muscles, joint capsules being taut. The closed pack position is full dorsiflexion. So we will not mobilize in this position, right? We don't want to crank somebody up into full dorsiflexion to try to mobilize them because that's where they have the most bony approximation. The open pack position is 10 degrees of plantar flexion, and that's about the position that you're going to rest in. If you just go lay down on your back and rest your ankles, you're typically going to fall into about 10 degrees of plantar flexion. The capsular pattern is loss of plantar flexion prior to loss of dorsiflexion with a greater loss of plantar flexion than dorsiflexion. Remember that the capsular pattern has to have the capsule involved. And so just because somebody loses dorsiflexion first doesn't mean that something's wrong with them. It just means that it's not following the capsular pattern. For dorsiflexion, arthrokinematics. This is my tibia and my fibula. My talus sits up inside of it, right? So for dorsiflexion, I'm going to roll anteriorly, glide posteriorly. For plantar flexion, I will roll posteriorly, glide anteriorly, right? I don't really like that picture, but if you guys do, it's in your textbook that helps to show it. Closed chain, if we're looking at that. So we're going to mobilize in our open chain positions at the ankle. So if I need to increase a patient's dorsiflexion, I'm going to glide them which way? Posteriorly, right? Because I roll anterior, glide posteriorly for dorsiflexion. If I need to increase plantar flexion, I'll glide anteriorly. Because the talocrural joint is a hinge joint, we are only going to focus on dorsiflexion, plantar flexion for the motions that are happening there in the arthrokinematics. Everything else happens as part of a combination of motions, right? Closed chain, we're just seeing the opposite, where if I go from this position into a dorsiflex position, my tibia and fibula have rolled and glided anteriorly. And then as I raise up, still in closed chain, my tibia and fibula roll and glide posteriorly. Joints of the phalanges of the foot, we've got the same ones that we had in the hand, except instead of C's, they're T's, because they're not carpals, they're tarsals. So your metatarsal phalangeal joint is going to be that most proximal one, and then you have your proximal interphalangeal joint, followed by your distal interphalangeal joint. Toe motions, curling your toes is toe flexion. Raising them up to the ceiling is toe extension. Abduction is separating your toes. Adduction is bringing your toes together. Remember that for the foot, we reference the second toe for midline. Don't be mad at me that it's different from the hand. It's just the way it is. Our MTPs are condyloid joints with 2 degrees of freedom, meaning they can flex and extend and ab and adduct. Flexion and extension occurs in the sagittal plane about a frontal axis, with the great toe having 0 to 45 degrees and the rest of them having 0 to 40 degrees. Extension is 0 to 90 degrees at the great toe and 0 to 45 degrees at the rest of your toes. And I think most everybody should be able to see that on their own feet. I don't know how comfortable all of you are sharing your toes specifically with one another, and so if you would like to assess that on your own independently at home tonight, you may, but just pay attention to the fact that your great toe has more motion than your other toes. Ab and adduction, our reference point is the second metatarsal. It occurs in the frontal plane about a sagittal axis. We don't measure this, so there's no norms to reference. It's just a matter of if you have a patient who is struggling with those motions at the toes, we need to know which landmark we are referencing which motion from in order to document it. Our MTP, not MPT, my bad, joint extension is the concave phalangeal surface rolls superiorly and glides inferiorly on the convex head of the metatarsal. So I'm not going to test you guys on toe mobilizations right now. I don't think that you're going to see that too regularly, and if you do get that clinical experience, I look forward to you being able to share with the rest of your classmates for that learning. But as far as focusing on arthrokinematics, I'd rather you guys focus on what's happening between the talus and the tibia and fibula than worrying about the toes. Okay? Your interphalangeal joints are hinge joints with 1 degree of freedom. We get flexion and extension, and again, those are not measured. Our tibia and fibula are the bones of our leg that make up the proximal portion of the ankle joint. We know our tibial plateau is where our femoral condyles rest on. We've got our tibial tuberosity. Our tibial crest runs down the length of the tibia and serves as a point of muscle attachment. Our interosseous membrane helps to connect our fibula and our tibia and allows for muscle attachments as well. Our fibula is not a weight-bearing bone. All of the weight of our body is borne through our tibia. Our fibula does not bear the weight. And we all already know where our fibular head is and how to palpate it, correct? Bones of the foot. So we've got our talus that is our most superior, where it articulates with the tibia and fibula. Directly underneath of our talus is our calcaneus, and our calcaneus is what ends up holding the weight. Why do you look confused, Hunter? Oh, it was a yawn. My
I'm
bad. So moving forward from our calcaneus, on the medial side we have our navicular. On the lateral side we have our cuboid, and then we have 3 cuneiforms that sit just anterior, or I guess anterior is probably, or distal to our navicular. So 3 cuneiforms, and then our metatarsals articulate with those. The navicular is one that you can palpate on the side of your foot, the navicular tuberosity. So if everybody wants to get the medial aspect of their foot and find that bony prominence sticking out right at about midfoot, mine's right where my finger is, that navicular tuberosity is something that we will look at to see if it falls in a weight-bearing position, to see if somebody has flat feet. And so being able to palpate that and identify where it is an important bony landmark.
So I don't want to throw back into the bus, but when she takes her Crocs off, she has flat feet, and I always like palpate. This is weird, but yeah, and she's flat foot, and then also I don't know how to explain.
Like collapses.
Yeah, her feet are.
Well, you'll have to get her some exercise, man. All right, so functional areas of the foot. Our foot is divided into 3 different sections: our forefoot, our midfoot, and our hindfoot. Our hindfoot is going to be made up of our talus and our calcaneus, and it's going to bear the brunt of the weight. Remember, we've got 3 weight-bearing points to our ankle and foot. Going to be through our calcaneus, our first metatarsal head, and our 5th metatarsal head. The majority of that weight goes through the calcaneus in our hind foot. Our midfoot's going to be made up of our navicular, our cuboid, and our 3 cuneiform bones. And then our forefoot is going to be made up of our metatarsals and our toes. And our forefoot is the portion of the foot that is designed to adapt to all ground surfaces and all those variabilities in shape. Got frantic writing going on. I'll wait a second. Everybody good? All right, our tibiofibular joints, we have 2 of them, a superior and an inferior, or a proximal and a distal, depending on the textbook of reference. We can have slight disarticulations of the proximal or distal tibiofibular joint, especially following ankle sprains, that can restrict motion, and so sometimes we need to look at the joint play between those joints in order to improve plantar flexion or dorsiflexion. So the tibia and fibula are joined for most of their length by the interosseous membrane. The proximal and distal tibiofibular joints are where they make their bony connections. The tibia is the weight-bearing bone of the leg. They make synovial joints that are reinforced by ligaments that limit motion. The distal joint is a syndesmosis joint. And here's just another picture of your ankle. So ankle talocrural joint, being the uniaxial hinge joint, is the articulation of the talus with the distal ends of the tibia and the fibula. The joint structure is a mortise, meaning the distal end of the tibia is notch-shaped, forming a superior and medial portions of the notch. The fibula is the lateral portion of the notch, and the talus fits into that notch. So syndesmosis, mortise, and talocrural are probably used more synonymously than they should be, especially in a clinical setting. And so understand that syndesmosis and mortise are utilized to reference the ankle joint pretty regularly. And this is a weight-bearing joint. The oblique axis of the lateral malleolus of the fibula is posterior to the medial malleolus of the tibia, causing that oblique axis, and why we get abduction with dorsiflexion and adduction with plantar flexion. My subtalar joint is the articulation between the talus and the calcaneus. What motions happen at my subtalar joint? Inversion, eversion. So it's the articulation of the distal surface of the talus and the proximal surface of the calcaneus, makes up part of the hind foot. It is a synovial joint where inversion and eversion occur. A patient who has undergone a triple arthrodesis has the subtalar joint eliminated, and so they lose inversion, eversion as part of the arthrodesis process. So they'll maintain plantar flexion, dorsiflexion, but they lose inversion, eversion because the subtalar joint doesn't exist following a triple arthrodesis. Everybody good? All right, transverse tarsal joint is going to separate the hind foot from the midfoot, and that's going to, go here, showing where my talus and calcaneus are going to articulate with my cuboid and my navicular. The anterior surface of the talus and calcaneus articulate with the posterior surfaces of the navicular and the cuboid, respectively. The demarcation between the hind foot and the midfoot, and they experience gliding motions at this joint. The midfoot includes the remaining intertarsal joints, so the talocalcaneonavicular, the calcaneocuboid, the cuneonavicular, the cuboid-navicular, the intercuneiform, and the cuneocuboid joints. So all of those midfoot bones articulate with one another, and they have these different articulation points that sometimes we need to just look at joint play for motion of the foot, depending on what deficits the patient is experiencing. So when you treat the foot, remember that it has multiple bones, and all of those articulations contribute to the motion that is necessary. Stiffness at one articulation can restrict motion somewhere else in the foot, and so sometimes we just need to assess joint play there. They're all synovial plane joints with minimal motion, but there's a roll and glide that occurs. Numerous ligaments support the joints and limit motion. We also have arches of the foot. We've got a medial and a lateral and a transverse. Our medial longitudinal arch runs the calcaneus is the base of the posterior leg, and the heads of the first three metatarsals are the base of the anterior leg. The talus, navicular, and three cuneiforms are the curved portions of the legs, with the talus being the keystone. So our medial longitudinal arch runs longitudinally along the foot on the medial aspect, right? This is the arch of your foot that should not fall in a weight-bearing position. It should not contact the ground in a weight-bearing position. Doesn't mean that's the case for every person, but it's not supposed to contact the ground. Our lateral longitudinal arch, calcaneus base of the posterior leg, the heads of the fourth and fifth metatarsals are the base of the anterior leg. The cuboid is the curved portion of the arch and the keystone. It is shallow, and it does flatten with weight bearing. And then the transverse arch of the foot runs transversely or horizontally. The cuboid and lateral cuneiform are the base of the lateral leg. The medial cuneiform is the base of the medial leg. The middle cuboid is the curved portion of the arch and the keystone, and it is also shallow and flattens with weight bearing. Ligaments that support the ankle and foot. We can see we've got our spring ligament down here, is a commonly injured ligament that causes chronic ankle instability. And so somebody who's had sprain of a spring ligament may require what types of interventions to be emphasized? Chronic ankle instability should be treated with proprioceptive interventions. Good job, Audrey. So looking, obviously, this is our medial aspect of the ankle, and we've got 4 parts of our deltoid ligament, and our posterior tibiotalar, anterior tibiotalar, tibionavicular, and tibiocalcaneal. that make up the deltoid ligament. And it is stronger than the ligaments on the other side. On the medial side, they will be named for the tibia first and then the bone in the foot. On the lateral side, they will be named for the bone in the foot first and then the fibula. And so that's something to pay attention to when you're looking at naming and identifying ligaments. But the most important thing to understand from this is that we have greater support on the medial aspect of the ankle. And so we have eversion sprains happen less commonly than inversion sprains because of the support provided through the deltoid ligament. Lateral ligaments, so we've got our posterior talofibular, our anterior talofibular, and our calcaneofibular. And you can see there's just not as much ligamentous support, and they're named backwards, so they probably don't work as well. God bless you. Support structures of the foot. Our short plantar ligament helps to maintain the medial and longitudinal arches along with our long plantar ligament, which fuses in with our plantar fascia. Our plantar fascia runs from our calcaneus up to our metatarsal heads to help provide structure and support to the foot and maintain the medial longitudinal arch in a weight-bearing position. Implications of the plantar fascia are seen regularly in therapy, and so we need to understand what effects can happen to shortening or tightening of the plantar fascia and what we need to treat to address it. Typically, the plantar fascia tightens it to offer support as a result of ankle weakness and intrinsic foot muscle weakness. And so when we don't have muscle activation to support the arches of the foot like they need to, it relies on the static support of the fascial structures. And that is how we typically have increases in irritation of the plantar fascia. Somebody's there. Support structures of the foot and arches. So we talked about our 3 weight-bearing points of contact in the foot. We're bearing weight through our 5th metatarsal head, our 1st metatarsal head, and our calcaneus. So I want everybody to stand up on one leg as soon as you have that written down. And I want you to feel the weight in your foot really transfer between those 3 points. If you try, you might be able to get a little bit of weight through one of the other metatarsal heads as you roll over that way. But your weight kind of just jumps between those 3 points. There's no way to bear it in between there. And so your body functions as a giant tripod, basically. Because tripods are the most stable structures. You can have a seat if you felt that. But you're basically standing on 2 tripods. It's just another close-up of your plantar fascia where you can see its attachment at the calcaneus and then the digital slips for each of the metatarsal heads. Irritation of the plantar fascia typically has increased pain initially in the day when it's been most shortened. Then pain decreases as the person walks on it and they're able to stretch it out a little bit until it reaches that fatigue point, and then it tightens back up. And so it's kind of an inverted bell curve on pain. Role of the plantar fascia in supporting the arches of the foot. The plantar fascia creates the windlass effect, which helps to increase the arch and create a rigid pivot point during heel off to toe off for a more efficient gait. So without the plantar fascia, we wouldn't be able to get this taut arch as we decrease weight bearing through the foot in that heel off to toe off sequence. And it wouldn't maintain the rigidity needed to have efficient motion and power through for gait. All right, so muscles of the leg, ankle, and foot. Extrinsic muscles include our superficial posterior group, which is going to have our gastroc, for plantar flexion and knee flexion, our soleus for plantar flexion, and our plantaris for plantar flexion and knee flexion. Our deep posterior group is going to include our tibialis posterior for plantar flexion and inversion, our flexor digitorum longus for MTP and IP flexion and plantar flexion and inversion, and our flexor hallucis longus for MTP and IP great toe flexion and plantar flexion and inversion. Our deep posterior group is often known as Tom, Dick, and Harry for tibialis posterior, flexor digitorum longus, and flexor hallucis longus, in the way that they hook around the medial malleolus as they go into the bottom of the foot. Tom, Dick, and Harry.
Okay.
Tibialis posterior, flexor digitorum longus, flexor hallucis longus. I can't go backwards.
Oh, you done clicked it?
Yeah. I'll return to the slide with you guys later, okay? Our anterior group is going to be made up of our tibialis anterior for dorsiflexion and inversion, extensor hallucis longus for MTP and IP great toe extension, dorsiflexion and inversion, and extensor digitorum longus for MTP and IP of the four lesser toes extension and dorsiflexion. And then our lateral group is going to be fibularis longus for eversion and plantar flexion, fibularis brevis for eversion and plantar flexion, and fibularis tertius for eversion and dorsiflexion. Intrinsic muscles of the plantar surface of the foot. So just like we had intrinsic and extrinsic muscles of the hand, we have intrinsic and extrinsic muscles of the foot. Intrinsic muscles of the foot don't cross the ankle, just like intrinsic muscles of the hand didn't cross the wrist. So our intrinsic muscles of the plantar surface of the foot, the first layer is our abductor hallucis, which causes abduction and flexion of the MTP of the great toe. Flexor digitorum brevis, which is flexion of the PIPs of the lesser four toes. And then abductor digiti minimi, which is abduction and flexion of the MTP of the fifth toe. Again, digiti minimi, same thing as with the hand. That was the pinky finger, well, it's pinky toe. And then hallucis is for our great toe or our big toe. It's just pollicis for our thumb, hallucis for our big toe. The second layer of intrinsic muscles on the plantar surface of the foot are going to include our quadratus plantae, which changes the line of pull of the flexor digitorum longus muscle, and then our lumbricals, which cause flexion of the MTPs with extension of the IPs, same as what our lumbricals in the hand do, right? Third layer is going to be flexor hallucis brevis, which is flexion of MTP of the great toe. Adductor hallucis is going to be adduction and flexion of MTP of the great toe. And then the fourth layer is going to be our dorsal interossi, which is abduction of the second through fourth toes. And our plantar interossi, which is going to be adduction of the third through fifth toes. So same as with the hand, it kind of cups based on which side you're trying to use it. Your foot does as well.
How many from your office?
No, it's
He's in Miss Scott's looking. Oh.
it's the guy that's over at the OTA looking at that.
First layer, is that the most superficial?
Yes.
Fourth is the deepest.
Yes.
Okay. Just making sure.
Yes, good clarification. But first layer is going to be most superficial, fourth is going to be the deepest. Intrinsic muscles of the dorsal surface of the foot. So extensor digitorum brevis is going to cause extension of the PIPs of the second through fifth toes. And extensor hallucis brevis is extension of the MTP of the great toe because it has hallucis in the name, right? So we just reviewed all of these. I hope going through these pictures will be quick and painless. But looking at our gastroc, we know that it crosses the knee. And so something that we're going to be paying attention to today when we do our goniometry is dorsiflexion with the knee extended and dorsiflexion with the knee flexed so that we can see the difference in what the patient's range of motion is. Gastroc causes knee flexion and ankle plantar flexion and is innervated by the tibial nerve. Our soleus and our plantaris So our soleus is a little bit deeper to our gastroc, right? But it does not cross the knee, so it's only going to contribute to ankle plantar flexion. Our plantaris does cross the knee in patients who have one, and so we're going to see a little bit of knee flexion contributed to from plantaris, but both are going to be innervated by the tibial nerve. And this is just showing you the difference between the location of the superficial posterior group. Going deep to those superficial posterior group, so our deep posterior group, we're going to get to tibialis posterior, which is Tom. See, look, I was already thinking ahead. I have him labeled for you guys. Originating from the interosseous membrane in adjacent tibia and fibula to insert on the navicular and most of the tarsals and metatarsals. Tibialis posterior causes inversion and plantar flexion and is innervated by the tibial nerve. And you can see Tom hooking around that medial malleolus there. Flexor hallucis longus, or hairy, originates on the posterior fibula and interosseous membrane to insert on the plantar surface on the base of the distal phalanx of the great toe. So it flexes the great toe and causes ankle inversion and plantar flexion and is innervated by the tibial nerve. And flexor digitorum longus stick originates on the posterior tibia to insert on the distal phalanx of the four lesser toes to flex the MTP and IP joints of the four lesser toes, also causing ankle inversion and plantar flexion, also innervated by the tibial nerve. I just didn't delete that apparently. And then this picture just helps show you the different layers if you need help to conceptualize where those run. It's something you can look at is how the Tom, Dick, and Harry weave around. So they have a medial to lateral orientation at the ankle, and then the way that they insert flip-flops. And it's not something that I want you guys to stress about. It's just a matter of understanding the changes in line of pull, and that's why we get contributions for inversion versus eversion based on their orientation at the ankle versus their orientation at the foot. So if you're struggling to understand which ones do which and need that clarification, come talk to me and we'll go a little bit deeper into the mechanics there, but otherwise just understand their actions. Okay? Tibialis anterior is going to originate on the proximal lateral tibia and interosseous membrane, insert on the first cuneiform and first metatarsal. Tibialis anterior is responsible for dorsiflexion and inversion and is innervated by deep fibular nerve. I feel like you guys should know that one for drop foot. We've talked about it enough. Extensor hallucis longus comes from the proximal anterior fibula and interosseous membrane to run to the dorsum of the base of the distal phalanx of the great toe to extend the first toe IP and MP joints. Also contributes to dorsiflexion and inversion. Innervated by
Deep fibular nerve.
Extensor digitorum longus originates on the proximal anterior fibula interosseous membrane, anterior lateral condyle of the tibia. Inserts on the dorsum of the distal phalanx of the four lesser toes. So we're not going anywhere near the great toe. And extends the MTP and IP joints of the four lesser toes and contributes to dorsiflexion. It is also innervated by the deep fibular nerve. So again, another picture just to show you the anatomical relationship of each of these muscle groups should that help you in your conceptualization of what these muscles do. And then moving out to our lateral group, we've got fibularis longus, which originates on the head of the fibula and interosseous membrane to insert on the plantar surface of the first cuneiform and metatarsal. It causes eversion and plantar flexion and is innervated by the superficial fibular nerve. Our fibularis brevis and fibularis tertius are essentially going to border the distal aspect of the fibula. And so fibularis brevis is going to run a little bit more posterior on that border, whereas fibularis tertius is going to run a little bit more anterior. And so fibularis brevis is going to cause a plantar flexion motion, whereas fibularis tertius is going to cause a dorsiflexion motion, just because of how they border either side of the fibula. Both are going to contribute to eversion because they're on the lateral aspect of the leg, but their positioning relative to the border of the fibula determines whether they contribute to plantar flexion or dorsiflexion. So fibularis brevis is going to contribute to plantar flexion. Fibularis tertius is going to contribute to dorsiflexion. Fibularis brevis is going to be innervated by the superficial fibular nerve. Fibularis tertius is a deeper nerve or deeper muscle, and so it is going to be innervated by the deep fibular nerve. Again, fun-filled picture should it help you conceptualize any of those things. Intrinsic muscles of the plantar surface, so looking at the first layer, again, that most superficial layer, we've got abductor digiti minimi, flexor digitorum brevis, and abductor hallucis. And then going into the second layer, we've got that quadratus plantae and flexor hallucis longus and flexor digitorum longus that will kind of come over from those extrinsic muscles and run through that second layer of intrinsic muscles. And then we can see our lumbricals in between those tendon bands. Then going down into our third layer, we've got flexor digiti minimi, flexor hallucis brevis, and our adductor hallucis. And you can see tibialis posterior wrapping around there on that medial aspect. And then we've got our dorsal and plantar interossi. Remember, our dorsal are going to abduct. Our plantar are going to adduct the toes. And then looking from the dorsal surface of the foot, we see extensor digitorum brevis and extensor digitorum longus lies over top of it. And then you can also see extensor hallucis brevis with extensor hallucis longus running over top of it. You look confused, Nautica?
That picture ain't on the page.
You guys don't have that one?
Well, that is not really confusing. Just the what? The next one? Got it.
Common pathologies of the foot and ankle. Shin splints. Who's ever had shin splints? They're fun, right? They're exercise-induced pain along the medial aspect of the tibia, typically felt along the tibial crest. It's caused by an inflammation of the periosteum of the tibia and is an overuse injury. Ankle sprains. The lateral ligament is the most frequently injured. Most common soft tissue injury in the body is an ankle sprain. Inversion sprains are more common. Why? What's the other ligament called? The deltoid ligament. So understanding that the strength of the deltoid ligament is why inversion sprains are more common than eversion sprains, and that ankle sprains in general are the most common soft tissue injury in the body. Avulsion fractures are something that can happen with ankle sprains when one of those ligaments pulls the bone away from the rest of the bone. Those are typically seen in very hard inversion sprains. If somebody goes down hard, they are at a greater risk of an avulsion fracture because just the tension that is pulled, and especially in a growing child where they don't have the epiphyseal plate sealed yet. But avulsion fractures are when that end piece of the bone comes off and sticks with the ligament, no longer sticking with the bone. Calcaneal tendonitis or Achilles tendonitis is inflammation of the calcaneal tendon at its insertion. A ruptured calcaneal tendon is when we have a complete tear of the Achilles, and it results in the loss of the ability to plantar flex because there's nothing pulling there anymore. An ankle fracture can involve one malleolus or both. It's called bimalleolar when it involves both. And then we've got calcaneus valgus and calcaneus varus. We talked a little bit about when we talked about genu valgus and genu varus and coxa valga and coxa varus. So Calcaneal valgus is where the distal aspect of the calcaneus is oriented away from midline. So standing behind a person, looking down the back of their leg, and then their foot kicks out like this. Calcaneal varus is going to be when their foot kicks in like this. So if you were to look at from straight down the Achilles, whether the heel goes this way or the heel goes this way, is going to determine whether it's calcaneal valgus or calcaneal varus. If I had a patient with a genu valgus, what would I expect at the calcaneus?
The varus.
The varus, exactly. Because the body wants to compensate and get you back to normal, right? So again, calcaneal valgus commonly occurs as a compensatory result of genu varus. Calcaneal varus occurs as a compensatory result of genu valgum. That's probably a better picture. I forgot I had that in there than trying to show you on my ankle. But calcaneal valgus, we see the calcaneus pointing away from midline. Calcaneal varus, we see the calcaneus pointing towards midline. Equinus foot is where the hind foot is fixed in plantar flexion. Calcaneal foot is where the hind foot is fixed in dorsiflexion. And so equinus foot, they tend to walk up on their toes, sort of like a horse, and that's why equinus is in the name. Calcaneal foot, they're forced to walk more on their calcaneus, and so it seems aptly named. Pes catus is a high medial longitudinal arch, and so that's high arches. Pes planus is a flat medial longitudinal arch, and so that's flat feet. Hallux valgus. So what's hallux mean? Big toe. Valgus means that it's going to point away from midline, right? Just remember that the foot has its own midline. So hallux valgus is when the great toe points away from the foot that it's on towards the other foot. And then hallux rigidus is a degenerative condition of the first MTP causing pain and loss of range of motion. Hammer toe is when we see PIPs flexed and DIPs extended, which is opposite of mallet toe, which would be the PIPs extended and the DIPs flexed. Claw toe seems aptly named. It's going to be flexion of both the PIP and the DIP so that your toes are like little claws. We'll take a break here in just a minute so that Hunter doesn't fall asleep on us. Metatarsalgia is going to be pain at the metatarsal heads. So algia being pain, right, in medical terminology, so metatarsal pain. Morton's neuroma is located typically happening between the third and fourth metatarsal heads, but it's basically just an irritation of a bundle of nerves within the foot, and that irritation then compresses in a small amount of space and can have those metatarsal heads pushed together even more in a weight-bearing position, which then puts pressure on the neuroma and causes increased pain. There's not much that we'll do about them from a physical therapy standpoint, but it's important to know about it. And then turf toe is a forced hyperextension of the MTP of the great toe. This is a common injury for athletes. And then plantar fasciitis is overuse injury, pain often in the heel during weight bearing, usually worse after sleeping with the foot in a plantar flex position. And then we can also see fractures of any of the toes, any of the metatarsals. Does anybody have any questions on the foot and ankle? Alrighty, let's take a 10-minute break and then we'll go over goniometry manual muscle testing of the foot and ankle, and you guys will have a lab to finish up the rest of the morning with.